I'm Juan Carlos Kaski. I'm the immediate past director of the Cardiovascular and Cell Sciences Research Institute at St. George's, University of London. Today I'm sort of coordinating this very large international meeting on treatment of cardiovascular disease in 2016, which has attracted over 600 participants from many countries around the world. Microvascular angina, which has been one of the topics of this symposium, encompasses a relatively large heterogeneous group of patients. Essentially, what defines microvascular angina is the occurrence of myocardial ischemia in the absence of obstructive coronary artery disease. In other words, patients with microvascular angina come to us with typical chest pain, which suggests coronary artery disease, but when we do an angiogram on these patients, find that the arteries are just not occluded at all. But despite this, there is a clear evidence for a reduction in blood flow that causes the symptom of angina. Microvascular angina can be triggered either by an inability of the microcirculation to dilate and increase blood flow, despite an increase in demand for this blood flow, because the microcirculation is unable really to respond to appropriate stimuli. And there are many reasons for that. The main reason is endothelial dysfunction, and endothelial dysfunction is associated with a number of traditional, conventional risk factors such as hypertension, dyslipidemia, obesity, the metabolic syndrome, smoking. All of these conditions, this inability of the microcirculation to respond to ordinary stimuli. Another important dynamic cause for microvascular angina is microvascular spasm. So in other words, the arteries really go into a very severe spasm that blocks the blood flow into the heart muscle, and that results in what we call myocardial ischemia, and it translates into the symptom of chest pain, but also into electrocardiographic changes suggestive of a reduction in blood flow. In some severe cases, the cardiac troponins will go up, indicating that there is damage to the heart muscle cells. So microvascular angina triggered by these functional mechanisms can go from a relatively trivial condition up to a very severe one that is able to impair function and damage the vessels. Less commonly, microvascular angina can be triggered by structural mechanisms. The microvessels can be in a way trapped by a very thickened heart muscle, like in patients with hypertension and left ventricular hypertrophy, people with aortic stenosis with left ventricular hypertrophy, or hypertrophic cardiomyopathy. In those cases, there is a very clear organic reason for the coronary microvessels not being able to function normally. And treating the baseline condition is usually quite effective to relieve this obstruction or pseudo-obstruction to the coronary blood flow. The investigation of microvascular angina has been pretty difficult until very recently, essentially because these vessels are very small in caliber, and therefore they're not accessible to angiography. And this could be one of the reasons why physicians have been focusing mainly on the large vessels, the epicardial vessels, and the whole strategy to diagnose the disease and to treat ischemia has been focused on the large arteries, obstructions to the large arteries. So this inability of our tools to visualize the microcirculation has actually delayed progress. Nowadays, we have some indirect ways of looking at the coronary microvessels and how they respond to different stimuli. For example, we can carry out myocardial perfusion studies with cardiac MRI, and we are able to see abnormalities in the subendocardium. So this is a test which is accessible to clinicians, pretty accessible to clinicians nowadays, and quite accurate at identifying these abnormalities in the vasodilatory ability of the coronary microcirculation. We can also use echocardiography to detect regional wall motion abnormalities in response to different stimuli. We can, if we take the patient to the catheter lab, carry out flow studies using a catheter to measure coronary blood flow in the catheter lab. We are able now to increase blood flow using drugs like adenosine, for example, and we can measure the velocity and the amount of blood flow that, or the increase in blood flow that results from the administration of these arteriolar vasodilators. So we have quite a few tools. Using acetylcholine during the angiography is a very, very good way of looking at coronary microvascular spasm. And we have carried out a study a couple of years ago in collaboration with Peter Ong and Udo Sekten from Stuttgart, which has shown a large proportion of patients with chest pain and non-obstructive coronary artery disease having microvascular spasm or diffuse distal epicardial spasm being responsible for their symptoms. So I would really encourage cardiologists around the world to use these accessible tools to diagnose the condition, because identifying coronary artery spasm immediately gives you a target for treatment. Discovering and understanding the mechanisms that lead to microvascular dysfunction and how microvascular dysfunction results in myocardial ischemia in these patients is extremely important and has actually opened new avenues for research, particularly research into technologies that allow us to investigate the microcirculation more accurately, but also trying to identify the right medication for these patients. At the moment, we are using drugs, pharmacological agents that are useful in patients with angina and conventional obstructive coronary artery disease. We know that the way the microvessels respond to these drugs is not as good as it is with problems in the macrocirculation, in the epicardial artery. So I think that the future probably, or progress in the future, will be related to us identifying drugs which act specifically against the mechanisms responsible for microvascular angina. Probably we will need to tailor the treatment, and we need to design drugs aimed at targeting specific pathways which result in this abnormal microvascular function.